Again, thank you to the organizers for inviting me. I will be talking about the chicken and egg type of relationship between sleep and clock function and neurodegeneration. And in particular, I'm going to be talking about Alzheimer disease. This is because Alzheimer disease is actually the most common neurodegenerative disease. It is not rare. And the Alzheimer Association estimates that by the year 2050, over 13 billion Americans, million Americans will have symptomatic Alzheimer's disease. And so now that it's 2020, the math is easy. Just add 30 to your age currently and figure out which of these colors you're going to be in. So if you're going to be less than 74, you're still okay. But as one ages, the risk of Alzheimer's disease increases. And your lifetime risk of developing Alzheimer's disease, if you are a man, it is close to 12%. If you're a woman, it is over 20%. So many of us in this room will develop Alzheimer's disease unless we can do something about it. Now, there are two pathological hallmarks of Alzheimer's disease. One is amyloid plaques, and this is when normal amyloid beta, which is normally released by neurons during neuronal activity, which is soluble, if that accumulates and clumps up, it becomes insoluble and it accumulates outside of neurons. And this occurs many years before the onset of any cognitive symptoms. So at least 10 to 15 years prior to the onset of any symptoms whatsoever, people have this pathology in their brain. A couple years before the onset of symptoms, tau also accumulates inside neurons in what are called tau tangles. And so there is this very long, what we call preclinical phase of Alzheimer's disease, during which there's disease pathology in the brain, but there are no apparent symptoms. Now, I think or others have reviewed the changes in sleep and circadian function with aging. Suffice it to say that there is less slow-wave sleep, there's more fragmentation of sleep, lighter sleep, and there's also, there tends to be an advance in the circadian phase. And there's also an increased prevalence of sleep disorders, particularly obstructive sleep apnea, which is the most common sleep disorder that we see in the sleep center nowadays. Now, in Alzheimer's disease, after people have what we call symptomatic Alzheimer's disease, where they have cognitive decline, sleep disturbances and circadian disturbances are exceedingly common. They are progressive, meaning that as people get worse and worse in terms of their cognitive function, their sleep-wake function also worsens. So there are the usual trends that are seen in aging, except worse, with one difference, which is that there seems to be a delay, meaning a later circadian phase, in contrast to normal aging or typical aging, where there is an advanced phase. And this is a very common problem in that even in people with milder symptomatic AD and are still living in the community, 25 to 40% of their caregivers report that the sleep-wake functions are bothersome or are causing problems in their day-to-day lives. And it's not just that people have symptoms at night, it's that they're sleepy and unable to function normally during the daytime because their wake function is poor too. And so this really impacts their function. They can't drive, they can't properly participate in therapies, they can't participate properly in social functions. And so this can cause a lot of distress among patients and their families. And then lastly, if people are not sleeping at night, they may get up and wander around. And the safety implications of this are a very common reason for institutionalization, which then ramps up exponentially the cost of care. And then about 10 years ago, I became interested in sleep disturbances in Alzheimer's disease. And I said, well, what happens during that 10, 20-year period when people have Alzheimer's disease in their brain, but they just don't know it. And so what we did is we studied cohorts that had been followed at the Alzheimer Disease Research Center, completely cognitively normal. These are people who are tested very extensively, and they are normal. The average age was around 65, and about a quarter of them had biomarker evidence of preclinical Alzheimer's disease based on their CSF. They wore an actigraph, which is an accelerometer, for 2 weeks, and we used validated algorithms to basically translate this to their sleep-wake functioning. And we found that the sleep efficiency, which is the percent of time in bed that one is actually sleeping, was reduced in those who had preclinical Alzheimer's disease. And then we went a step further and said, well, let's kind of divide these people by sleep efficiency, meaning the really good sleepers, people who spend 90% or more of their time in bed sleeping, medium sleepers, and poor sleepers, less than 75% of their time in bed sleeping. And we found that the poor sleepers had a 5.6 odds ratio of having preclinical Alzheimer's disease compared to the good sleepers. Now these are, again, completely normal, otherwise healthy, older individuals. And so this was very intriguing that, wow, sleep may be abnormal in these people who otherwise have no other symptoms of brain dysfunction. Similar findings have been reported now by multiple groups. This is from Adam Spira at Hopkins, and they used amyloid scans. And so you can see that this person has less amyloid binding compared to this medium, and then a lot of amyloid binding. And the amount of amyloid plaques present on PIB-PET correlated with self-reported short sleep, so sleeping less than 6 hours compared to greater than 7 hours, I believe. Another study by Kate Sprecher showed that by questionnaire, when they asked people the ratio of their tau to A beta 42 in their spinal fluid, which is a sort of an Alzheimer disease specific biomarker ratio, as their sleep was less adequate, or as they got sleepier in the daytime, or as their overall sleep problems increased, that biomarker level was higher. And similar studies have been reported from many other groups now. So in addition to sleep problems being present in people with preclinical Alzheimer's disease, Eric Music and I went back and looked at that cohort we had first studied for sleep to say, well, he's a circadian researcher. We said, well, what's going on with their circadian function? And we found that people who have poor or high intradaily variability, this means a lot of back and forth between activity rest over the course of the 24-hour day, the higher that index was, that correlated with a higher amount of this tau over A beta 42 ratio. And that circadian measure is actually not correlated with any of the sleep measures. It truly is a measure of fragmentation of rest activity rhythms over the 24-hour period. So, so basically, preclinical Alzheimer's disease, or AD pathology in the brain, seems to cause both sleep problems as well as circadian fragmentation. So just to summarize this background portion, aging is associated with sleep and circadian disturbances, and Alzheimer's disease is associated with more severe, as well as some different sleep and circadian disturbances. And I think importantly for us to note is that these disturbances are present in preclinical Alzheimer's disease when they have zero other symptoms of Alzheimer's disease. So, people ask, well, what came first, sleep problems or Alzheimer's disease pathology? And I have randomly assigned sleep problems to be the egg and Alzheimer's disease pathology to be the chicken. So I'm first going to present to you the data that support the egg to chicken direction. So I first became interested in this field of sleep and neurodegeneration when this paper came out back, I guess, over 10 years ago that showed that amyloid beta levels increase during wakefulness in the dark for mice and decrease during sleep. And this same finding was replicated in humans. The single line is the amount of sleep, and the double lines are two different forms of amyloid beta. In humans, however, there is a little bit of a lag because we can't measure the amyloid beta levels up in the brain. We have to get it in the lumbar region. So after the peak of sleep around 4 a.m., about 5 to 5.5 hours later is the nadir, or the low point of amyloid beta measured in the spinal fluid. Now in the mouse study, they found that when mice were deprived of sleep by giving them orexin, they stayed awake more, and also their amyloid beta did not go down like it's supposed to. So acute sleep deprivation increased soluble amyloid beta. This has again been replicated in humans. This study was done by Sharon Ohms and colleagues. She was a visiting grad student in my lab, but she actually did this in the Netherlands, where when these were young, healthy individuals, the sleep-deprived people had a higher level of amyloid beta in the morning compared to the people who were allowed to sleep normally. A similar study was done by Brendan Lucy at Washington University. Again, they put in a lumbar catheter and measured amyloid beta levels. And the red are the people who were sleep deprived. And you can see that that is higher than the blue and green lines. One of them had normal sleep and the other one had sleep enhancement, but there was no difference between those two. It's really the sleep deprivation that raised the levels throughout the course of the night. And then in terms of what part of sleep is affecting the levels of amyloid beta, we tested whether it was slow wave activity. And the reason why we tested this was that slow wave activity is pretty much kind of the most opposite of waking activity. So EEG activity in REM, for example, is very similar to wake. And so we thought it would be better to try to specifically decrease the thing that seems to be most sleep-like about sleep. And so what we did is we took healthy, normal individuals between 35 and 65, and they had two separate studies. On one night, they just slept normally in a sham condition. On the other night, they wore earphones, and over every 10 seconds, the EEG was processed. If they had slow wave activity, they would get a little beep. And that beep would get louder and louder and louder every 10 seconds, enough to disrupt them out of slow wave sleep. And what we found is that the more we were able to disrupt the slow wave activity, so more to the right here, the more their amyloid beta levels increased the next morning compared to their sham night. And all the lumbar punctures were done at the same time at 9:30 at the expected nadir of amyloid beta. There was no relationship between differences in REM, non-REM, or total sleep time. And so it seems to be slow wave activity disruption specifically, which increases amyloid beta. Now back to the mouse study. In the mouse study, they then did chronic sleep deprivation in a mouse AD model, and they found that the ones that were sleep deprived chronically got more plaques. These are the yucky black things compared to the control mice. Unfortunately, you cannot do this to humans. But there are some longitudinal studies that give us a hint that perhaps sleep problems over the long term may lead to amyloid disease pathology. So this is from Andrew Lim, who's now at Toronto. I think this is the Rush cohort. So there's quite a few older individuals, cognitively normal. They used actigraphy to look at sleep fragmentation, and they found that people with the worst sleep fragmentation had a 1.5 times risk of developing dementia over about 3 years compared to the best sleepers. However, recall that I told you that the preclinical phase of Alzheimer's disease is at least 10 years, if not more. And so due to this long preclinical phase, these prospective studies in humans, at least that have been published so far, are actually cross-sectional. We're probably catching the people who have AD pathology and have poor sleep, rather than catching people who had sleep problems for a long time, which then led to AD pathology. Another study that was really compelling was from the apnea cohort. This is a research cohort for Alzheimer's disease. Very large study, I think about 2,500 people. And they just asked people, do you have sleep apnea? And also, if you have Alzheimer's disease or mild cognitive impairment, what was the age that you were diagnosed? And you can see that people who said they got mild cognitive impairment, the green line are the people who said they had obstructive sleep apnea, and the blue are the people who didn't. And this is for people who said they had Alzheimer's disease. And there was a 13-year difference between these two and a 5-year difference between these two. So this was not only statistically significant, that's very clinically significant. I mean, if you imagine 5 years of not having dementia, that is a very big deal. And I wanted to make a side note about obstructive sleep apnea, which is the most common sleep disorder that we see in the sleep clinic. It's not a neurological disorder, but unfortunately causes neurological problems. It's a disorder where people's upper airway collapses during sleep. There is repeated hypoxia as well as sleep disruption. And when we studied individuals with obstructive sleep apnea compared to those who did not, what we found is that in contrast to our hypothesis, their levels of amyloid beta are actually lower, as are several other proteins that are derived in the central nervous system. Their total protein was the same, however. People with sleep apnea also lost the relationship between slow-wave sleep and amyloid beta, in that usually if you take a group of people, those who have higher amounts of slow-wave activity have lower amyloid beta. But that relationship did not exist in people with obstructive sleep apnea. And so our interpretation of these data is that perhaps trying to breathe against a closed throat creates pressure changes in the skull or in the venous system that leads to decreased clearance via the glymphatic mechanism, perhaps, out of the interstitial space and into the CSF where we can measure the proteins. So just to review the things I talked about, so to go from sleep disturbance to amyloid deposition, is that if there is sleep disturbance, there is decreased slow-wave activity, and this likely leads to relatively increased amyloid beta release. Also, there may be decreased glymphatic clearance as well, and Matt Walker reviewed that mechanism previously. So for both those reasons, you would expect increased amyloid beta levels over the long term, which would then increase the risk of amyloid deposition years later. And then, of course, there's at least kind of a 10 to 15-year process where that then leads to symptomatic Alzheimer's disease. Additionally, we all know that if you don't sleep well, you're going to have cognitive problems. So you can imagine that for two people with the same amount of brain pathology, that the one who doesn't sleep well is more likely to be diagnosed with having cognitive problems or dementia. Also, I wanted to mention that obstructive sleep apnea leads to sleep disturbance, decreased glymphatic clearance, also leads to hypoxia, which contributes to increased amyloid beta levels, and has systemic effects on cardiovascular, actually vascular risk, and general inflammation and neuroinflammation, which may all contribute to the transition from preclinical to symptomatic AD. And in one review, they estimated that sleep disturbance may actually account for 15% of Alzheimer's disease risk. But I did want to go the other way and review the ways in which AD pathology may then lead to sleep problems. So this is a study that also came out of the Holtzman lab by Ji-Hoon Roh. And in this study, they used mice that develop amyloid plaques, usually around 6 to 9 months. And they found that their sleep-wake cycle kind of gets messed up as they age. And while they're young, they have this nice diurnal variation in their amyloid beta, but that flattens out as they get older. And this is exactly what we see in humans as well, where young normal controls have this nice variation in their amyloid beta, but as they get older, it flattens out, and you really don't see it once they have amyloid plaques. Now, what was cool about the mouse study is that they vaccinated these mice so that they cleared away those amyloid plaques. And that actually rescued both their sleep-wake behavior as well as this diurnal variation in amyloid beta. And so this suggests that there's something about having amyloid plaques that leads to changes or problems with sleep-wake over the course of the 24-hour day. Also, as Matt Walker previously presented, in this human study, which was very elegant, they showed that the amyloid plaques may actually affect slow-wave activity, which then affects memory function. Oh, I started 5 minutes late. All right. And so there are multiple potential mechanisms, which I mentioned. Also, just to mention that amyloid may deposit in the retina as well, which can then impact light, which is the strongest Zeitgeber for our circadian system. And also, just to mention, there is a mouse AD model that doesn't have plaques or tangles, but they have sleep problems too. So there may be some other mechanism that we just don't know that's affecting sleep. Also, once people develop cognitive symptoms, there are a variety of reasons why they may perpetuate their sleep-wake dysfunction. And then medications, even ones that seem innocuous, like blood pressure medications, may affect sleep-wake problems. And then mood disorders are also very common and may add to sleep dysfunction. So just to fill in the other side of the graph, once people have amyloid deposition, they may have injury to sleep or circadian brain regions, which then directly affects sleep ability. But then we also saw that amyloid plaques themselves lead to decreased slow-wave activity, kind of forming a second feedback loop, which then also separately affects memory function. Once people develop even subtle symptoms of cognitive dysfunction, they may retire, they may become less active, have less regular activity. And this may then contribute to sleep disturbance. And just of note, in terms of improving your sleep, the one thing you can do today to get more slow-wave activity tonight is to exercise. So if you don't exercise, you kind of lose that bonus slow waves that you would have gotten acutely. Also, as I mentioned, medications, which elderly people tend to be on lots of medications, may affect sleep. Also don't want to forget our clock friends. So if you have a clock injury, that then has secondary downstream effects on sleep. So this is kind of depressing to look at. That's a lot of arrows and feedback loops. But in a way, I think of each of these arrows as actually an opportunity for intervention. Uh-oh. Okay, so there are each of these arrows may be intervenable by behavioral methods, medications, et cetera. So I think that because of sort of this feedback loop nature, we'll need to be consider even multimodal strategies trying to attack multiple of these arrows. Lastly, I do think it's important as we design studies that we actually look for preclinical Alzheimer's disease using biomarkers so that we can better determine the direction of causality of some of these associations. And then also I think it's important to assess specific components of sleep, not just sleep in general, but looking at slow waves or spindles or being more specific about the things that we measure and also assessing for sleep disorders in AD-related research so that we can be more impactful and hopefully reduce the burden of Alzheimer's disease and sleep dysfunction in our communities. All right, that's big.
I think maybe we can take one quick question now, and then we can move and continue the discussion at the poster session.
Wow.
Yes?
Perhaps you can just talk me through a little bit more about those paradoxical findings in sleep apnea that you showed. It doesn't seem quite to fit. You mind just running that past me again?
Sure. So I guess one thing that I didn't show is that in people without sleep apnea, there is a relationship between the amount of slow wave activity and amyloid beta, where more slow wave activity, there's less amyloid beta. You'll lose that relationship in in people with sleep apnea. So there's a disconnect between the brain activity and the amyloid beta levels. Separately, we see that the levels of proteins that are made in the central nervous system, they tend to be all decreased in people with obstructive sleep apnea, whereas total protein is not. So our hypothesis to try to explain these two pieces of information is that perhaps those proteins, including amyloid beta, which are made in the brain, are not making it into the spinal fluid where we're measuring it, and that is why the levels are decreased.
Okay, Luis says.
What about treated OSA versus untreated OSA?
So when we did the study, we restudied the treated OSA, but not the untreated, which in retrospect was a design flaw. But people who are treated and are able to use the CPAP machines, which we offered for treatment. One, they had a normalization in the relationship between slow wave activity and amyloid beta. When we took the people who had more severe obstructive sleep apnea, who had more prominently reduced levels of the CNS proteins, they tended to kind of increase and be equal to the other groups.